So good morning, students. I will be beginning with your toxicology part 2. Um, on the previous time, I talked about the heavy metal poisoning, the general principles to manage poisoning, and then I talked about the chelating agents, in which I talked about a few of the chelating agents, but the remaining were left over there. So I will be continuing first with the chelating agents. So I have talked about dimercaprol, succimer, and penicillamine. So I will be continuing with the disodium edetate and desferrioxamine and diferipron. Okay, so these chelating agent I am going to talk today. Then I will be talking about the common drugs the patients come with the poisoning with, and how we are going to manage such patients. And the third part will be the snake and the scorpion poisoning, how we are going to manage such patients. Okay, so coming to the calcium disodium edetate, it has high affinity for lead, zinc, cadmium, manganese, and copper, and towards some radioactive metals also. What it does, it due to the presence of the calcium in its molecule, it helps in the removal of the metals with by exchanging it with the calcium in its molecule. So and one very important property is that it is highly ionized, so it is not absorbed orally, and that's why it acts extracellularly mainly, and it gets excreted rapidly through the kidney. And when given, mostly it is given by IV route, as it is highly ionized, so it is not absorbed through the gut, and the intramuscular route administration is very painful, and it has no CSF penetration. So we use it in lead poisoning and the other iron, zinc, copper, manganese poisoning, but not in the mercury poisoning, as it forms complexes which are poisonous. The common ideas with calcium disodium edetate is that it produces kidney damage because the complex is dissociates in the renal tubules. Therefore, how we can prevent this kidney damage is by enhancing the urine flow. That means more intake of the fluid. Other areas are febrile reactions, which includes the chills, body ache, malaise, tiredness, etc. And the third is the anaphylactic reactions. So these are the common adverse effect which this chelating agent causes. The other is the desferrioxamine, which is commonly used in iron overdose or over poisoning. It is an actinomycete which contains the ferrioxamine, which is an iron-containing compound. The name has been derived from that. And the chemical removal of iron from the body, it is desferrioxamine. And 1 gram will help in removing 85 milligram of elemental iron. So how it is going to act in our body is that desferrioxamine, it binds with the ferric iron molecules and forms the stable non-toxic compound. This helps in removal of loose iron which is present in the body as hemosiderin and ferritin, but not from the hemoglobin or cytochrome. And it has got low affinity towards the body calcium also. So that is how this desferrioxamine is going to act. It is used by subcutaneous or intravenous route in acute iron poisoning, transfusion cirrhosis, and the common ADR with desferrioxamine is histamine release, which leads to fall in blood pressure and allergic reactions. Coming to the acute iron poisoning, how it occurs, it is very common in the infants and the children when they consume around 10 to 20 milligram iron tablets, or if they consume more than 60 milligram of iron per kg body weight. The symptoms include vomiting, abdominal pain, hematemesis, diarrhea, lethargy, cyanosis, dehydration, convulsion, and shock, and finally death. So these are the symptoms, and in the pathology we can find that there are hemorrhage and inflammation in the gut, hepatic necrosis, and the brain damage. So the aim of treatment for acute iron poisoning is first to remove the excess iron which is present in the body by inducing vomiting or the gastric lavage with soda bicarb and egg yolk or milk. They are given orally to form complex with iron. Then we have the desferrioxamine, that is the chelating agent, which will help by binding to the iron already present inside the body. And it is given by the intramuscular or the subcutaneous route, or we can give it by IV route also. And the aim is to keep the iron level below 200 microgram per deciliter. And we also give the supportive therapy with fluid and the correction of acidosis is also to be done in such patients. Coming to another chelating agent, that is deferriprone. The common drawback with the desferrioxamine was it was to be administered systemically, but deferriprone is orally active iron chelating agent, and tablets of deferriprone are available, and they are to be given in patients of transfusion cirrhosis in thalassemia patients, and they are also used in iron poisoning, but they are less effective as compared to desferrioxamine. And the dose is 50 to 100 milligram per kg in 4 divided doses. So common areas associated with it are joint pain, anorexia, vomiting, and agranulocytosis. Coming to the different, that was all about the chelating agents. Next part is the drug poisoning, which are the common drugs which we are going to take, and many a times patients do come to our emergency conditions. They are having the poisoning, or they have taken overdose, or they have been given overdose of certain compounds. Common ones are the aspirin, paracetamol, antihistaminics, tricyclic antidepressants, anticholinesterase poisoning, then barbiturate, and the benzodiazepine poisoning. So one by one, we will talk about what will be the presentation, how we are going to manage these conditions. Coming to the aspirin poisoning, it is acetyl salicylic acid, and commonly the poisoning occurs due to idiosyncrasy or overdose of aspirin, and it is more common with the children. It is more common in the children, and the fatal dose for adults it is 15 to 30 grams, and the fatal period is between few minutes to several hours, and serious toxicity is seen when the level plasma concentration becomes more than 50 milligram per deciliter. So what will be the signs and symptoms which we will find is the general symptoms such as giddiness, buzzing in the ear, edema of face and eyelids, rash, dyspnea. There will be nausea, vomiting, hematemesis, melena, because aspirin causes irritation of the GI mucosa, and due to hypoprothrombinemia, there can be chances of fetal hemorrhage also. Then, due to the stimulation of the respiratory centers, hypopnea is also seen in such patients. There is electrolyte imbalance, acidotic breathing, and then the patients can also have hallucination, hyperpyrexia, convulsions, and death due to respiratory and the CVS collapse. So then how we are going to manage patient of aspirin poisoning is that we do external cooling of such patients. Then we, to avoid the further absorption, we do the gastric lavage with warm water and 5% sodium bicarbonate to correct the acidosis is also given. We use the IV fluids to replace the sodium, potassium, and the bicarbonates. We use the alkaline diuresis or the hemodialysis in the patients who are having severe poisoning. Then we can also go for blood transfusion and vitamin K supplementation if bleeding is there. So the next drug is paracetamol poisoning. The poisoning of paracetamol occurs because of the metabolite of phenacetin, and it is common in children with low hepatic glucuronide conjugating ability. Basically, paracetamol gets metabolized in the liver only, and the fatal dose of paracetamol is more than 150 milligram per kg, or more than 10 grams for adults. and period is 3 to 5 days is the fatal period of after paracetamol poisoning. So how the poisoning with paracetamol occurs is that there is a metabolite known as N-acetyl P-benzoquinonamine, and it is a minor metabolite which is formed from paracetamol, and it gets deoxified in the liver by glucuronidation. So what happens when there is a consumption of large dose of paracetamol? The glucuronidation of the drug gets saturated. So more of this minor metabolite gets formed in the body, and it then binds with covalently with the liver and the renal tubules, and then further leads to the necrosis of the liver cells or the hepatocytes. And in the chronic alcoholics also, there occurs more production of this metabolite, because in the chronic alcoholics there is induction of the cytochrome P2E1, which causes excessive metabolism and production of this metabolite. So in such cases 5 to 6 gram of paracetamol is enough to produce hepatotoxicity. What will be the signs and the symptoms? In the early stage, that is known as the first stage, the patient presents with nausea, vomiting, abdominal pain, with no impairment of consciousness. After 12 to 18 hours, which will be the second phase, the patient presents with centilobular hepatic necrosis, there is renal tubular necrosis, there is hypoglycemia, and after 2 days, that is the third stage, when the patient presents or has the jaundice, hepatic failure, GI bleeding, cerebral edema, death occurs if the plasma level is more than 200 microgram per ml at 4 hours, or more than more than 30 microgram per ml at 15 hours. So the monitoring, plasma level monitoring, is important to note down uh, how much the concentration is there in the plasma. Then how we are going to treat the patients of paracetamol poisoning is that we do gastric lavage within 4 hours of the overdose. We give the activated charcoal orally to prevent further absorption. We use for the hypoglycemia correction, we give the dextrose infusion, the bicarbonate infusion, vitamin K and blood transfusion to prevent the hemorrhage. And the specific antidote for paracetamol poisoning is N-acetylcysteine. N-acetylcysteine is the antidote for paracetamol poisoning. What it does, it replenishes the glutathione stores and prevents the binding of the toxic metabolite to the liver cellular constituents. So it will prevent the necrosis of the hepatocytes, and it is used in the moderate to severe poisoning, and we have to administer it within 16 to 24 hours of the poisoning, and it can be given by IV infusion as 150 milligram per kg over 15 minutes, and same has to be repeated for the next 20 after 20 hours. And or alternatively, we can give it orally 140 milligram per kg initial dose, followed by 75 milligram per kg orally every 4 hourly, so as to administer total 17 doses. Next, we have the antihistaminics. The antihistaminics have the property as anticholinergic, anti-adrenergic, and the anti-serotonergic properties are there. So the side effects or the adverse effects with these poisoning will be corresponding to their pharmacological properties. So the patients with antihistaminic poisoning will present with signs and symptoms. There will be initial depression followed by CNS excitation. The anticholinergic side effects, we will have the dry mouth, dry eye, dilated pupil, urinary retention, blurred vision, dizziness, palpitation, pyrexia without sweating. So these will be the anticholinergic side effects. And when in the large doses, it can lead to disorientation, hallucination, and even coma. There can be also excitatory effects such as tremors, convulsion, nystagmus. So the fatal dose is 1 gram, and how we are going to treat patient is that we do gastric lavage to prevent further absorption by warm water and sodium bicarbonate. And for convulsion, we are going to give diazepam 10 gram by intravenous route. The next drug is the tricyclic antidepressants. And for tricyclic antidepressants, it is very common poisoning and it can be fatal. And the main effect is that on the heart and the brain. What it does, because of the anticholinergic effect, it is going to affect our brain, and the quinidine-like effect produces the effect on the heart. So coming to the presentation, the anticholinergic effects will be dry mouth, dry eye, dilated pupil, urinary retention, blurred vision, dizziness, palpitation, etc. And the CNS effects will be confusion, delirium, coma, convulsion, myoclonus, and the respiratory depression. And due to the quinidine effects, there will be cardiac toxicity leading to heart block, asystole, bradycardia, or tachycardia, and the ventricular dysrhythmias. On the ECG, we can find broadening of the QRS complex, widened QT interval, and the fatal dose is 1 to 2 gram. And coming to the treatment, the main treatment is supportive. We give the IV fluids if the blood pressure is low. We control the convulsion with the diazepam. We give the activated charcoal to prevent further absorption and correct hypoxia if present with oxygen. And sodium bicarbonate is administered to correct the acidosis. And we correct the arrhythmias, if any, with the propanol or the lidocaine. Coming to anticholinesterase poisoning, the anticholinesterase poisoning occurs because when organophosphate they bind irreversibly with the enzyme which metabolizes the acetylcholine, that is the acetylcholinesterase. There is abundance of acetylcholine which will be present at the synapses and the neuromuscular junctions. So what happens? The patient will present with the muscarinic side effects such as in the eye, there will be miosis, blurred vision, eye ache, conjunctival congestion, brow ache, and from the gland there will be profuse sweating, salivation, rhinorrhea, and lacrimation. The GI motility will be increased, and that leads to nausea, vomiting, diarrhea with abdominal cramps. The nicotinic, the genitourinary system, we will find there is an urgency of urination and spontaneous micturition, penile erection when there is severe poisoning, and difficulty in breathing is seen because of bronchospasm, increased secretion from the bronchial tissues, and then there is decreased pulse rate or bradycardia, hypotension, collapse, etc. The nicotinic effects, early there will be fasciculation, and in the late there will be weakness followed by paralysis. In the CNS effects, there will be anxiety, insomnia, nightmares, confusion, tremors, convulsions, respiratory depression, circulatory collapse, etc. So how we are going to treat a patient if he or she comes to our emergency with organophosphate poisoning? First of all, we start with the general measures. We terminate the exposure of the drug. We remove the clothes so that further absorption, as the organophosphate is very lipophilic, it gets absorbed from the skin. So, and if the drug is present in the powder form on the skin, the further absorption will occur. So what we will do, we will remove the clothes, we will wash the whole of the body of the patient, then we will do the gastric lavage, and then we will clean the airways for respiration, we will provide oxygen therapy for respiration if needed. Then we supplement the IV fluids for correction of the dehydration and the shock, and for convulsion we give the IV diazepam. Apart of that, we have the specific antidotes for the organophosphate poisoning, that is the atropine and the oximes. Atropine, they are not going to reverse the nicotinic effects. And we have to administer it immediately, 1 to 2 milligram IM or by IV route, and it has to be repeated every 15 minutes until we see the signs of atropinization, that is dryness of mouth, reversal of meiosis, that is mydriasis is seen, or heart rate is above 70 per minute. Then coming to the other, that is the acetylcholinesterase enzyme reactivators, the oximes. They are effective only in the organophosphate poisoning, but not in the carbamates, since the enzyme, both the sites are occupied by the carbamates, so there is no binding site for the auxins. So the hydrolysis will not occur. But in the organophosphate poisoning, the auxins accelerate the hydrolysis of organophosphates from the enzyme, that thereby help in the cure of such patients. So it is pralidoxin, which is given by slow IV route, 1 to 2 gram, and for children it is 20 to 40 milligram per kg dose. Next is the barbiturates. Barbiturates are given commonly in the preoperative sedation and seizure disorders. The longer acting one is the phenobarbital, short acting one are the pentobarbital, and the ultra short acting one are the thiopentone sodium or the methoxytone. So fatal dose for the short acting one is 2 to 3 gram, and for the phenobarbital it is 5 to 10 gram. So coming to the symptoms, it is the CNS depression is seen with the barbiturates. The patient present with stupor or coma, peripheral circulatory collapse, weak and the rapid pulse, cold, clammy skin, slow, rapid and shallow breathing, pupils constricted and reacting to light initially, but subsequently they become they are paralytically dilated. Then there is pulmonary edema, bronchopneumonia, acute renal shutdown, etc. So how we are going to manage such patient is that we hospitalize such patient, we provide support towards the vital functions, we correct the airways, breathing, circulation, we prevent the further absorption of drug by inducing MSCs, gastric lavage, activated charcoal, we increase the elimination of drug by alkaline diuresis, and we provide the prophylactic antibiotic doses, and then we use the peritoneal dialysis, hemodialysis, or the hemoperfusion to increase the rate of elimination of the drug from the body. The next drug is the benzodiazepine poisoning, and its toxicity occurs because its toxicity resembles, the symptoms resembles with the sedative actions on the CNS, and larger doses they will produce the neuromuscular blockade. By IV route, they will produce the peripheral vasodilation, which leads to fall in the blood pressure and the shock. And they decrease the alveolar ventilation, induce carbon dioxide narcosis in patients who are with chronic obstructive pulmonary diseases, and they causes respiratory depressant effect with sedation, sedative drugs when they are given concomitantly. And death occurs in patients who are concurrently injected with ethanol or the CNS depressants. And IV dosing leads to hypotension and the respiratory depression. This further leads to death of the patient. So the patient presents with the signs and symptoms. The mild ones are the drowsiness, ataxia, weakness, and the moderate to severe ones are the vertigo, slurred speech, nystagmus, partial ptosis, lethargy, hypotension, respiratory depression, and coma, which has been staged into stage 1 and the stage 2. And in the stage 1, the patient is responsive to the painful stimuli, but not to the verbal or the tactile stimuli, and there is no disturbance in the respiration or blood pressure. While in the stage 2, the patient is unconscious and not responsive to even to the painful stimuli, but that there is no disturbance in respiration or the blood pressure. How we are going to manage such patient is by providing life supportive procedures and symptomatic or the specific treatment. We correct the airways, breathing, and circulation. We provide the IV fluids, and then we do the endotracheal intubation for assisted ventilation. Supplemental oxygen is also to be given to such patient. And for decontamination, we wash the stomach within 16 to 12 hours by using the activated charcoal. And but emesis is contraindicated in such patients who are having diazepam poisoning. Specific antidote for the benzodiazepine poisoning is the flumazenil. And for correction of the hypotension, we use the dopamine. The antidote treatment is with flumazenil, which helps in reversing coma, which is induced by the benzodiazepine, and it is a competitive antagonist for benzodiazepine in the benzodiazepine receptors, and 0.2 milligram per minute IV is given till the patient regains consciousness. So that was all about the tablets or drugs which we commonly encounter poisoning in our emergency. The next part is that of the snake bite. In India, there are around 200 species of snakes, and only 52 of these species they are poisonous. And the poisonous snakes they have been classified based on the venom or the poison they secrete. Okay. So they have been classified as elapids, vipers, and the sea snake. Elapids produce the neurotoxic venoms. Vipers they produce the vasculotoxic, and the sea snake they produce the myotoxic poisons. The new elapids include the cobra, king cobra, carrot, or the banded carrot, while the vipers they are the vasculotoxic, and the sea snakes are the myotoxics. In the neurotoxic venom, there is muscular weakness of legs, paralysis of face, throat, and respiration. But there are no local symptoms of at the site of the bite. That is minimum with the neurotoxic venom. In the vasculotoxic venom, there is enzymatic destruction of the cell walls and coagulation disorder. There is local oozing of hemolytic bloods and spread of cellulitis. And in the myotoxic venom, there is muscular pain, myoglobinuria, which ends in respiratory failure. So these are the photographs of cobra, king cobra, common carrot, and the sea snake. The other ones are the vipers, the Indian Russell vipers, the Indian green pit vipers. Then the important fact which we have to remember is that the snake bite majority, that is around 80%, is caused by the non-venomous snake. And venomous snake, about 50% the bite are dry. That means no venom is injected. If a venomous snake also bites, there are chances that 50% of the bite they are dry. So how we are going to treat? The first and the foremost thing is that we have to allay the anxiety and the fright which commonly the patient encounters when they get a snake bite. So then we have to prevent the spread of the venom by immobilization, as the spread of the venom occurs to the lymphatic system. And we have to apply tourniquet proximally. We have to clean the wound in season, and suction has to be done to prevent further spread. Then there are specific antidotes, that is the anti-venom, and in our country, India, we have the polyvalent anti-venom, which has been derived against the venom from cobra, Russell viper, carrot, sauce-killed viper, and monovalent vaccines are not available in India. And each vial around 10 ml that neutralizes this. This is the amount of the poison which get neutralized by using a single vial. And snake injects same amount of venom whether they are going to a single bite will transfer a constant amount of or a particular amount of the poison. So it doesn't varies whether it has a kid has been uh, um, kid has got a bite or an adult. So the dose of this anti-snake venom remains the same for either the children or the adults. So this is the while here you can see how much milligram it is going to neutralize for the different Indian cobra, common carrot, Russell viper, all things are written. How we are going to reconstitute is that this freeze-dried lipophilized anti-snake venom powder is there in this vial, and we have to put 10 ml of sterile distilled water per vial to prepare this constituents. How we are going to administer? There are two methods. One is the IV push method and the infusion method. So IV push, the venom anti-venom is given by slow IV injection, not more than 2 ml per minute. And by infusion, what happens that we dilute it approximately to 5 to 10 ml of isotonic fluid per kg body weight. That means we have to give 250 to 500 ml of normal saline or 5% dextrose and infuse at a constant rate over a period around 1 hour. So coming to the dosing of this anti-venom, that first we grade the severity of envenomation. It is graded into no envenomation, mild, moderate, and the severe one. So these are the grading, how we are going to grade, and based on the dose is also dependent. For the mild one, we use 5 vials, that means 50 ml of the anti-snake venom has to be used. For the moderate one, we use 5 to 10 vials, that is 50 to 100 ml. And for the severe cases, severe envenomation is done, then we use 10 to 20 vials, that is 100 to 200 ml of the anti-snake venom has to be used. The next and the last part is the scorpion stings. So the anatomical of the scorpion, that is present at the tail portion, that delivers the sting is known as talison. And the venom of the scorpion that is injected is mainly toxalbumin, and it produces neurotoxic and the hemotoxic actions. And the red scorpions venom, they are cardiotoxics. So what will be the signs and symptoms of scorpion bite? Local irritation will be there, redness and the burning, pain will be there, headache, nausea, vomiting, profuse perspiration, muscular cramps, and finally leading to coma. The children, they develop pulmonary edema. There can be neurological manifestation if persistence up to 1 week duration. How we are going to treat such patients is that what we do, we apply bandage near the affected part, right higher to the site of sting, and then we immobilize it. We wash the site of the wound with plain water, ammonia, and potassium permanganate. And then we locally infiltrate anesthesia to subside the pain. We inject calcium gluconate 10 ml of 10% solution slowly IV, and that helps in relieving of the muscular cramps. But we do not cut into the wound or apply suction as we do in case of the snake bite. So that was all about toxicology. If you have any query or any question, you can ask me by sending me messages, or you can call me at my through my mobile, or you can send a mail to me if you have any particular query. I will be more than happy if you have any query in the toxicology part.